Okay, welcome back. We are now going to discuss about the lab diagnostic features, grading, staging, and the immunohistochemistry, some tumor biomarkers in case of the tumors. Okay, in the lab diagnosis, we perform the excision biopsy, needle aspiration, and cytologic smears. Now, in excision biopsy, generally we need to take out the cells from the gray area. Gray area in the sense not from the extremes like the periphery or the central necrotic area, because periphery is not representative. It usually does not have the cells, proper tumor cells, and this would be the central necrotic area. So central necrotic area also we won't find good uh, good, we will not be able to find a good sample. Now both these cytologic smears and the needle aspiration we are going to discuss in a moment. Then after the excision and biopsy or the needle aspiration, we send our sample for the either for the quick frozen or for the cytogenic flow cytometry, molecular diagnosis, or usually in the olden days for the paraffin wax sections. Now, FNAC, fine needle aspiration cytology, is usually preferred in case of the superficial tumors, probably because they are easily accessible, and therefore it's most common for the breast, thyroid, and lymph node being the most accessible, and therefore they are superficial too. Okay, cytogenic smear. Now, the pap smear is widely used in case of the CA cervix as a screening method for the CA cervix, and this method is so much efficient that it has reduced the cases of CA cervix remarkably. And this is probably because it's a screening. It's one of the best screening method, and it helps to diagnose the cervical cancer early, even before it has metastasized or has invaded. So this is one of a important point, takeaway point. Now, the cytogenic smears can also be used. This is usually the idea here is that the cells that usually shed away, as in case of the cervix or in the endometrium, or in case of the gastric cells, prostate cells, or the bladder cells, or these cells periodically they are shedded, and this provides a uh, because of this property we are able to make a smear. And when we prepare a smear, we generally try to differentiate between the malignant, dysplastic, or the normal cell. We look at the architecture, what is the morphology of the nuclei and the cytoplasm of the parent cell, and in comparison to the other cells, or a group of the cells. So sometimes, however, there is a limitation of this method, the smear method, is that we when there are poorly differentiated cells, we cannot say that they are due to the parent cell tumor itself, or they have metastasized from some other location. So in those cases, we use the immunohistochemistry and flow cytometry. We are going to discuss both of these in a moment. Okay, the immunohistochemistry. Now, this is very important as a principle, because it is important in clinically as well as it often shows up on the examinations. So, immunohistochemistry is very helpful in case of the poorly differentiated tumors, because the tumors that are usually malignant, uh, poorly differentiated tumors are usually malignant, and hence we are not able to identify the origin of the tissue. Now, if we are not able to tell the origin, how can we do the therapeutic measures, or because we have the drugs which are targeted to the receptors of the particular tissue, so we cannot have the therapeutic advantage. Moreover, sometimes the tissue may metastasize also. So if the tumor is already poorly differentiated, how we would be able to tell that from where it has arisen? Okay, so poorly different, it helps. The immunohistochemistry method is very helpful in case of the finding the tissue of origin from the for the poorly differentiated tumors. It, as I said, it is used for the therapeutic role and also for prognostic features. We would discuss the examples in a moment. Okay, I have included tables for the immunohistochemistry, that the stains that specifically target the intermediate filament or the proteins or some markers. But I know that these are some stuff that you need to remember. However, I'll try my best to make it as painless as possible for you. Okay, so the if the cells are laminin positive, let's say we put a stain and that stain marks for the laminin, and now that there is a change in color, and we see that the cells are laminin positive. Now what do we conclude? The cells are from the nuclear lamina. If the cells are vimentin positive, similarly, we can say the cells are from the mesenchymal cell. Now, mesenchymal cell. So, if I say you have a sarcoma, or if I say you have a chondroma, then can you guess that what would be the intermediate filament, or which immunohistochemical stain would be positive? Yes, it would be vimentin positive. Again, can I ask you the question over here that if the cells are neurofilament positive, then the tumor is likely to be of the neurons. Now, again, we have the glial fibrillary acidic protein, the GFAP, for the glial cell tumors, and the cytokeratin is for epithelium. Now, cytokeratin has different kinds of acidic or basic stains, but we need not go into such details. And this much is enough for the purpose of examinations and also clinically. Now, the PSA is useful. The prostate specific antigen is used for the prostate epithelium, and the estrogen receptor, progesterone receptor, and the HER2. These are very important for the breast cancer. Particularly the the estrogen receptor positive cells usually respond to the tamoxifen therapy, and the estrogen negative are having a poorer prognosis because they would be having recurrence. Even the cells that are both PR and ER negative have more poor prognosis in comparison to the ER positive or the PR positive cells. Another is the HER2. Now the HER2 is the protein product of the ERBB2 gene, and the HER2 is important particularly because there is a drug, the Herceptin, that targets the HER2 protein. Herceptin is the cancer drug Herceptin that targets HER2. So there is a tie-in from the pharmacology too. So these are very important in for the purposes of examinations. Now CD20 is you must remember this, that CD20 is for B cell lympho is for the as a tumor marker for the B cell tumors. CD3 for the T cell, and Hodgkin lymphoma we use both CD15 and CD20. For thyroid follicles, we use thyroglobulin, which is you can recall we have this thyroglobulin in the thyroid follicular cells. Chromogranin is for the neuroendocrine cells, and the neuroendocrine cells have usually the carcinoid tumor or the squamous cell carcinoma of lung. The carcinoid tumor has a good prognosis, the squamous cell carcinoma of the lung has a poorer prognosis. Now S100 is used for melanoma. Probably you would be able to just remember all these once you go through them again. Okay. Okay, flow cytometry. The idea here is that we use specific antibodies that targeted against the specific receptor or any other cell, which are linked to the fluorescent dye, which when we add the reagent from externally, they start to produce color. Now the advantage is here is that we can detect multiple antigens in one sample instead of taking 10 samples and adding the immunohistochemical stain to all the samples individually, we are able to have multiple antigens detected in one go. Now, this flow cytometry is usually used in the liquid tumors such as the leukemia, B-cell lymphoma, or T-cell lymphoma, and even myeloid tumors. Okay, now tumor biomarkers. Tumor biomarkers are usually the enzymes, proteins, hormones, even antigens. Okay, so again, it's these are the examples, and what can I do? I have to include them over here because they are again important clinically and even for the examinations. Now, there are hormones like calcitonin, which increases. Of course, you can imagine that thyroid gland usually increases the calcitonin. Now, in case of the PTHRP, the PTHRP, what is the full form PTHRP? It's parathyroid hormone related protein, and this is increased in case of the breast carcinoma or the squamous cell carcinoma of the lung. And now, what would be the result of increase in PTHRP? It would be hypercalcemia. It would be hypercalcemia, because remember, the parathyroid gland, what it does is produces the osteoclastic activity. The purpose of the parathyroid hormone is to increase the calcium levels in the blood. Now, the human chorionic gonadotrophin, of course, you can imagine here, is that trophoblastic tumors or the germ cell tumors. Now, some proteins and the antigens, which are the prostate-specific antigens for the prostate cancer, not hard to imagine here because of the prostate. Immunoglobulin, again, it's easy to imagine that it's because in multiple myeloma we have the immunoglobulin light chains that are increasing the numbers. Okay, and remember from our first lecture is that in the multiple myeloma we have the monoclonal antibodies like the Benz-Jones proteins detected in the urine sample too. Now, and alpha-fetoprotein you can detect in the hepatocellular carcinoma and germ cell tumor. The hepatocellular carcinoma, not a very important one, but particular low yield over here, but I have included it. The carcinoembryonic antigen, yes, it is important for the colon, pancreas, and lung. Now, it is also useful in stomach, heart, and breast and ovary, but we have other tumor markers for the same. Like I said, for ovarian carcinoma and breast cancer, we have the CA125 and CA153. And for the colon, pancreatic, lung, bladder cancers, we generally have the TP53 variants. Now, a very important take-home point is that tumor markers are absolutely not the definitive diagnosis. Now, if we have the PSA raised, I cannot say for sure that it's because of prostate cancer, because usually all these tumor markers have low specificity and low sensitivity. So low sensitivity and low specificity. So the biopsy is quintessential for the absolute diagnosis. I want to hammer home this message that biopsy is a must. The tumor markers are only useful for as a screening method or as a suggestive of the tumor, but they are not the absolute diagnostic features. So tumor markers can be used as a screening methods, or we can use the for the effectiveness of the therapy, as in example of the ER receptors, the cells that are ER positive in case of the breast carcinoma, they respond to the tamoxifen therapy. And the third point would be that they are monitoring recurrence after excision. Let's say, for example, we have a patient who's prostate cancer, who presented with prostate cancer, and we have excised surgically the tumor, and now a year later the patient comes again and with the PSA level raised. Now, what can we say? Are these PSA levels raised? Then we can say that the PSA is because of the prostate cancer. However, again, I want to say here that the excision again is a mist. The PSA levels raised year after also, we cannot say that it is because of the prostate cancer. But still, we can use the tumor markers in the monitoring recurrence. Now, again, this point, I don't know how many times I have to say this, but biopsy is required. And by this time, it might be clear to you that without biopsy, there is no definitive diagnosis. Now, grading of the tumor. Now, grading is based on the differentiation of the cells. Now, when I have a slide under microscope, I look for whether the tumor is the cells are poorly differentiated or well differentiated. I look for the morphology of the nucleus, cytoplasm, and does it ask the question, does it resemble to the parent tissue or not? Because the generally the poorer the differentiation, poor the prognosis. Why? Because the poorer differentiation usually points towards the malignancy. Now this is not the absolute thing, but still generally speaking, the poorer the differentiation generally points towards the malignant nature. Now this grading is variable for the different tumors, and we need not go in such details. At present, this much is enough for the purposes of examination. Okay. Now, staging of the tumors. How the tumors are staged based on the size, shape. Earlier, but nowadays we have this TNM staging method. Now, before we go in further, I need to make sure to that you understand that the staging is a key prognostic factor. It is even more important from the grading. Now, there are different stages from 0 to 4 on basis how much it has invaded, or based on the size or the nodal involvement or the metastasis. Now, what is the TNM staging method? The TNM staging, first of all, T represents the tumor size and invasion. Now, size is usually important in the case of solid tumors. Let's say, for example, we have breast tumor or the prostate cancer. However, the invasion is important in the cancers which are in cavities like colon carcinoma, or sometimes size and the invasion both are important in case of the ovarian carcinoma. Um, Now, the next thing would be the nodal involvement. The nodal involvement would include if the cells have involved the lymph nodes, nearby lymph nodes or not, and the metastasis. Usually, the metastasis can be via the lymphatic route, also it can be from the blood. Now, the metastatic is a very important prognostic factor. Itself, single most important prognostic factor, if I say, it would be metastasis, right? And say, for example, we have a N0, then it represents no nodal involvement, and we have T0, so it involves no invasion. Or this is how this is different for different tumors, but I have just included here some broad things to have a big picture in the mind. Okay, so the last point is that the after resection only we are able to the stage. See, only after resection the surgeon performs the surgery or removes the tumor. We get to the pathology lab and we see under the microscope. Then only then we are able to stage the tumor. Lastly, I would like to discuss a very important point, is that the malignant tumors have metastatic potential. Now, from the first lecture, this thing I am just pointing it out again and again, but it's a very important take-home point, because the examiners love to go after this. The malignant tumors have a metastatic potential and the benign tumors never metastasize. This is by definition that the benign tumors are never metastasize. Okay, the benign tumor may invade. Now, benign tumors usually don't invade, are less invasive. However, they may invade, but they absolutely don't metastasize. This is what makes them different from the malignant tumor. With this, we can conclude our topic of the clinical aspects, and now we would be going with the carcinogenesis in the next lecture.